A 22-year-old woman is brought to the emergency department by her boyfriend. He reports that he found her next to a bottle of cold medicine after they had been in an argument, after which she refused to be brought to the hospital until the boyfriend noticed she was acting increasingly lethargic. A day later, the patient has a history of major depressive disorder. On examination, the patient appears mildly jaundiced and has abdominal tenderness on palpation. Which of the following findings is most likely to also be found in this patient? Choice A, yawning. Choice B, bradycardia. Choice C, hypoglycemia. Choice D, mydriasis. Or choice E, respiratory alkalosis. I'll wait 5 seconds and answer a question. Alright, so this patient took some kind of medicine, overdosed on it. She does have major depressive disorder, which is kind of buzzy, but of course that by itself doesn't really narrow things down for us. We were told it's a bottle of cold medicine, and she's acting lethargic and is jaundiced, which suggests to us that she might have hepatic failure, liver failure. Plus the fact that this is a day later should make us most suspicious of acetaminophen poisoning, or paracetamol, Tylenol basically. And since we're suspecting liver failure, then it's pretty likely that gluconeogenesis will be disrupted somehow, and that's why choice C, hypoglycemia, is the best answer here. So this question is a little bit vague, but let's try to look at some of the other answer choices here and see how well they fit. Choice A, yawning. When questions on USMLE give you yawning in terms of some kind of overdose or withdrawal, the thing that you probably think of most is opioid withdrawal. And this patient just doesn't really look like an opioid withdrawal picture at all. That would have basically secretions coming out a lot of her body. She would have lacrimation, rhinorrhea. She would have goosebumps, piloerection, and mydriasis, which is a blown pupil, because opioid intoxication would be the opposite, right? You would have like hypoactive bowel and meiosis. Whatever the case, hepatic injury isn't typical for opioid intoxication or withdrawal. I mean, yes, if you have very severe opioid intoxication, then maybe you'll see some hepatic damage, but the vignette just doesn't really fit. And it's not really typical anyway. Choice B, bradycardia. First thing I would think of typically is like organophosphate poisoning or possibly beta blocker abuse. Possibly some antiarrhythmics can also lead to bradycardia. If this was organophosphate poisoning, you would get, what you would think of with cholinergic poisoning, which is dumbbells, diarrhea, urination, meiosis, bronchorrhea, bradycardia, emesis, lacrimation, lethargy, salivation, sweating. So basically you have secretions coming out of everywhere, and bradycardia, bronchoconstriction, stuff like that. Some people get really confused about organophosphate poisoning and what it looks like. The really short way of thinking about it is really just, it's basically the rest and digest, aka parasympathetic response, turned up to 11, right? Because you have meiosis, your pupils shrink, you have slow breaths, your heart slows down, your gut gets active, you vomit, you poop, you pee, you get tired. Pretty much the only exception to muscarinic poisoning, as far as parasympathetic versus muscarinic, is sweating. Because sweating is a sympathetic reaction, but it's one of the only really noticeable sympathetic reactions you get out of organophosphate poisoning, which is normally just a bunch of parasympathetic reactions. So anyway, moving on, beta blockers or any kind of antiarrhythmic. Technically, a lot of those can cause bradycardia, but jaundice is really not typical of any of these, so they're not the best answer. Choice D, mydriasis. Well, we already talked about this for opioid withdrawal, but of course mydriasis, blown pupil, can also be seen in stimulant abuse. So of course that can mean things like amphetamines, cocaine. But this patient was specifically described to us as being lethargic, so that makes stimulant abuse a little bit unlikely. And we already talked about how opioid abuse and opioid withdrawal just doesn't really fit this patient. Choice E, respiratory alkalosis. Some of you might have picked this because you might have been thinking, oh, maybe she took aspirin, because we were told cold medicine. So of course, quite important for you to know that aspirin does in fact cause a respiratory alkalosis and a metabolic acidosis. Aspirin's kind of a weird drug in that it can stimulate the respiratory centers of your brain and cause you to breathe faster, which causes the respiratory alkalosis. But because aspirin salicylic acid itself is an acid, it can actually lead to metabolic acidosis as well. Just one of those weird things. But again, in this case, yes, this patient did take cold medicine, but aspirin just normally doesn't cause liver failure like what this question seems like. So going back to this question, like I said, acetaminophen poisoning, usually about 24 hours later, you start having more noticeable liver failure symptoms. And the reason this happens is because acetaminophen is metabolized into N-acetyl-P-benzoquinolamine. No idea if I said that properly, but it's NAPQ for short. And NAPQ depletes glutathione, which eventually leads to damage of the hepatic cells. So you can, of course, treat this with activated charcoal in an acute setting if it's only been a few hours since ingestion. But if not, you're going to have to give N-acetylcysteine, NAC, to replace the glutathione in the patient. And if it goes on for way too long, a couple days, it can lead to acute liver failure, and you're going to need to go as far as a liver transplant sometimes. Okay, I hope this video was helpful. I'll see you in the next one.